Distinguished panelists, guests, and colleagues from across the continent, good morning. Greetings from Indonesia. It is an honor to contribute to this conversation, even if only through a video recording, as the global health community gathered here in Geneva, a city that has long served as a hub for shaping global health dialogue and decision-making. The theme of this side event, From Chaos to Care, is not rhetoric. It is a precise description of the moment we are in. The global health architecture is under strain. Geopolitical fragmentation, reduced financing, and a fundamental mismatch between the system we have been trying to build and the communities we have pledged to serve. My name is Hidro, the president of Harkat Negeri University. I come to this conversation as educator, as a leadership practitioner, as collaborator, as someone whose career has been shaped for decades of experience dealing with the Indonesian governance. I want to open my speech with a candid observation. The global health architecture was already under significant stress even before recent crisis brought in deeper fault lines into full view. So, why does a gathering like this matter, bringing together civil society, patient advocates, the private sectors, philanthropists, researchers, practitioners, multilateral leaders, and policymakers? Because no single actor, however well-resourced, can navigate us from chaos to care alone. Today's global challenge, fiscal contraction, shifting multilateral commitment, and rising demand of health system are not aberration to be managed. They are structural invitation to build differently. Building differently requires precisely the kind of cross-sector partnership that brings us together today. These challenges are what shaped the purpose of Primary Healthcare Impact Lab, or field, anchored in Indonesia. CISDI, Harkat Negeri University, PT Tamaris Hidro Group, and also Harvard Medical School came together to establish field as a cross-sector collaboration platform. Each partner brings something distinct: academic rigor and student engagement, policy expertise and community proximity, sustainable capital, and knowledge partner. No single actor can deliver people-centered primary healthcare system strengthening alone. Together, we are building the condition under which it becomes possible, with lessons we believe are relevant to LMICs more broadly. As the founder of Harkat Negeri University, I believe a university's responsibility does not end at the lecture hall. The knowledge we generate, the student we engage, and the institution trust we carry are assets that belong to the society we exist to serve. We are present in Tegal, a small city in Indonesia that is neither a capital or showcase, because if a model like field cannot work in a place like this, then it cannot claim to work at all. This brought us into a lesson. In a global health system that is searching for anchors of continuity and trust, universities in the global south have a special important role to play as co-architects of solutions that are grounded in local realities and connected to global communities. The global health architecture will only be as strong as it's connected to the communities it serves. Field is beginning its work at the local level, in Brebes, in Tegal, in rural area in Indonesia, because that is where health system either function or fail. The lesson from the work must be able to travel upward into policy, into financing decision, and into conversation happening like in this room today, at the global level. We are here in Geneva at a moment of genuine consequence. The chaos is real, but so it's the opportunity. What this convening can do is to demonstrate that when sectors line together, share diagnosis, and commit to structures of partnership design that center communities, the architecture of care can be rebuilt better and more durably than before. Thank you.
Distinguished panelists, guests, and colleagues, good morning. Greetings from Indonesia. It is a genuine privilege to be part of this conversation. I stand before you today not as a policymaker, a researcher, or a health professional, but as someone who comes from the private sectors. My name is Muhammad Syahrial, and I'm the President Director of PT Tamaris Hidro, an Indonesian company whose core business is renewable energy. So the question worth asking openly is, what am I doing here? Delivering a keynote speech at a side event of the World Health Assembly, speaking about global challenges, and as we will come to, about primary healthcare. The answer, I believe, begins with how we understand the global challenges. The crisis we face today, from climate disruption to pandemic risks, from financing shocks to communities left without adequate care, do not stop at the boundaries of any one sector. I do think there is a growing understanding among business leaders in Indonesia. And beyond that, the well-being of communities is not separate from sustainability of what we built. That is what brought me to this conversation and eventually to Primary Healthcare Impact Lab, or we know as PHIL, an initiative that has been mentioned by Pak Sudirman before. As a private sector partnership in PHIL, what I would describe as an alternative partnership model, our role has been part of a genuine rethinking of how different sectors can work together. The global challenges we face have brought us to a moment where domestic resource mobilization is no longer optional. Governments cannot do it alone. International financing is under pressure. And so private sector investment, including from companies like ours, whose primary business is not health, is increasingly being invited to contribute in ways that it has not been expected before. This relates to what the business community sometimes called creating shared value, the idea that private sector participation in addressing social and development challenges. When we joined PHIL, we were not writing a check in exchange for a logo placement. We were committing capital to a partnership that we believe addresses a structural gap with anticipated long-term positive consequences for the country, Indonesia. This is also for the communities we work alongside our business every day. PHIL is one attempt to work through these challenges in practice with lessons that I believe applicable to other LMICs. I hope that what this gathering demonstrates is that rebuilding the global health architecture is not a task for any single sector. It requires all of us, including those of us who come from the world of business, to show up with both willingness and commitment to contribute. Thank you so much.
The direction of that change is clear. There is very strong calls for greater country ownership. Health sovereignty has come up a lot this week. More accountability, more coherence within the system. But how we actually get there and how each sector plays a role in giving up power, in stepping into new responsibilities, is the part that I think is a bit more difficult for us to discuss, and particularly in some of the decision-making fora here at the World Health Assembly. That is what we are going to do here today with some wonderful leaders from really a broad cross-section of global health actors, civil society, multilaterals, academia, private sector, and of course lived experience all play a really important part in this conversation. So as we have this panel discussion today, it will run for about 45 minutes and leave some generous time for Q&A from the audience, so please have your questions ready. We're going to keep returning to this question. In this new paradigm, in this new global health architecture, what does each player and each sector have to give up, and what does it need to step into to make this new system truly country-led, coherent, and people-centered? So I'm now going to introduce each of our panelists, invite you to join me on the stage one by one, starting with Dia Saminasi, the founder and CEO of CISDI, host of this morning's event, and a former senior advisor to the WHO Director General on Gender and Youth, and a fellow Lancet Commissioner on the Lancet Global Health Commission for People-Centered Care for Universal Health Coverage. Dia, I'd love to invite you to the stage. Thank you. We also have Dr. Kumanan Razanthan, who is Executive Director of the WHO's Alliance for Health Policy and Systems Research, and a leading thinker on this exact issue we'll be discussing today. We have Mikel Gagne-Lavali, the Deputy Executive Director of the Pandemic Fund, and before that was involved in leading the G20 and G7 health negotiations with the French Ministry of Health. Welcome, Mikel. We have Lutz Hegman, President of Global Health and Swiss Country Affairs at Novartis, where he leads the Global Health Unit's work on inclusive access for medicines and innovations in low and middle income countries, and a fellow advisor on the Lancet Commission on People-Centered Care. We have David Duong, Dr. David Duong, Director of our program in Global Primary Healthcare at Harvard Medical School and the Brigham and Women's, a primary care physician and co-lead on the Lancet Commission. And finally, last but not least, Ms. Anita Sabidi, a strong patient advocate and voice from Indonesia, representing the International Diabetes Federation, as well as the local chapter, Persada Muda Indonesia. Having lived with diabetes for the last 28 or so years, you bring a really important perspective to this panel. And now I will join you up on stage. So we're going to give the host's right of beginning to Ms. Dia Saminasi to open us up with this panel. And our question to get things going is, coming from Indonesia, from the global south at civil society, what does this call for a reformed global health architecture require? And perhaps you could share a little bit about Phil and why that's in part an answer to this question.
Thank you, Beth, and thank you, fellow panelists, for graciously accepting our invite to come and speak this morning. I'm Dia Saminasi, and to add to the long list of what I am, that Dr. Bethany Holt just described, I'm also a co-founder of PHIL. And so PHIL, or Primary Healthcare Impact Lab, is actually the fruit of labor of love between 3 people and 3 organizations. So it's me, Mr. Sudirman Said, and Mr. Muhammad Shahrial, an unlikely union if we can put it together. The discussion about Primary Healthcare Impact Lab came from chaos, actually, that happened early last year. I think among the 3 organizations, CISDI, WHA, and Tamaris Hidro, I think CISDI felt the impact of the chaos more than the other 2 organizations. At that time, I think it was exactly almost 14 months ago that I and CISDI realized that this is a different world altogether, that changes are not just change, it's just everything is just a collapse. And of course, CISDI has been in the field for 12 years, and we have grown from 6 when we started back in 2014 into now 120 people. And we operated across Indonesia, eventually I think it's virtually everywhere in Indonesia. We have been in one place or another at some point throughout those 12 years. And the dependency on traditional donors or development partners, as you put it, was high. because that was how the dynamics was shaped. That as civil society organization, you seek out funding from external of the country, because in the country the choices were limited, meaning that you either utilize state or government funding, or you find funding in short term, in small, with smaller value than the traditional donors, and then it is labeled as CSR. And CISDI was not set up to just implement. CISDI was built to have a vision, to dream big, to innovate, and to execute long term, and to have sustainability. So that change in the global health architecture in early 2025 was a prompt for me to shift gears. And then at that time, it was the beginning of my relationship with the global primary healthcare team at the Harvard Medical School as a Lancet Commission. And I went to the two partners in Indonesia and asked if I have this big idea to build something that is deliberately designed to do research from communities and for communities. Would they be interested? Will the university be interested? And the answer was positive on that side. And then I said, well, we cannot do it just us. It has to be, we have to invite someone or an organization with academic rigor. And who else to turn to but Dr. David Wong and Dr. Bethany Holt and their wonderful team. And so they said yes. And then it began the journey of Primary Healthcare Impact Lab. And I think it was also David that pointed to me that this is not something that is ordinary, because it came from Indonesia, it is built for Indonesia, but the actual impact and design can actually reach wider than just Indonesia. And so we reframe it into a center of excellence for the region, and now it's our roadmap, so to speak. But all this wouldn't have happened if there was no chaos. And I think the chaos was an opportunity for us to reframe things the way it could have been reframed. It could have been framed from the very beginning. And now we are retracing our step and then reframing everything and sharing our journey and our stories to the public. So the Primary Healthcare Impact Lab was launched in Indonesia, in Jakarta last week, the 7th of May. Work has begun since the beginning of the year, actually since January of 2026. And we have just recently finalized our first quarterly report, and we will do direct community engagement starting in June with the strong support of the team, the CISDI team, the university team, the private sector team, and of course our knowledge partner, the Harvard Medical School team. So it is actually, it feels like I'm living in a dream, because there is no better way to rearrange care than going back to the roots of what does care mean for the people and the communities we serve. Thank you.
Thank you, Dia. And we'll love to come back to later in the discussion just what it means to start with the needs of community and people with lived experience. But first, I want to turn to Kumunan, and I think Dia's given us a really powerful example of what chaos helped to create, a real sort of country-led, country-financed model for primary care research and innovation. The two of you recently wrote an article published in Nature, which I think helps us zoom out a little bit and think about the different ways in which care and global health needs to be done, in different contexts and different functions. Could you walk us through that thinking and share a bit about what you think that means for how global health needs to be financed and structured going forward?
Thanks, Bethany, and good morning, everyone. And firstly, congratulations to my good friend Dia and all the colleagues. It's an incredible partnership that is showing that out of, as you say, crisis, we always say there's opportunity. Sometimes we don't take the opportunities. Luke and I were actually discussing that. Did we take some of the opportunities from the crisis of COVID-19? And some of them we did, but many we didn't. So congratulations, how wonderful to hear. You're such a leader and dynamo in your institution, and what a great partnership with colleagues and the people, unlikely suspects, to really build a regional hub on primary healthcare. We're better to do it than in Indonesia. So congratulations, dear, and I really look forward to working with you as we have done for so many years and seeing what this will contribute to a very exciting region. So yes, our contribution to the global health architecture reform industry last year, although as one of my colleagues at WHA said, he said, oh, you got it quite early, was that really, I've been working in global health for over 20 years, and global health has achieved many good things, and we know what those are. I mean, incredible reductions in child mortality, sort of improvements and some things that weren't even considered possible in terms of some of the infectious disease epidemics, improvements in global health security. Those things should not be sniffed at. Those are significant achievements. And yet, the world is a very different place than it was 25 years ago, when the current contours of our global health architecture essentially were set, or even than 80 years ago, when some of our institutions, including the institution that the Alliance is hosted at, the World Health Organization, was set up. And that has been a period of unprecedented progress in human history. There are many flaws with the international order, but we should not forget that really has contributed to incredible economic progress, social progress, and health progress. However, this current crisis has shown that our architecture is not fit for purpose. And like with many crises, they can seem to occur suddenly, but when you look back, you realize that the seeds of these crises have been laid over decades, right? In that our systems struggle to change, and particularly when things seem to be going well. So what we aim to do in this paper with a really interesting group of people, with a great discussion, was to sort of say, what should be the functions of the global health architecture in this new era? And there's a lot of debate on this, but what we basically said, we came up with sort of a taxonomy of 5 sets of functions, or 6 sets of functions, and then also looked at the different contexts. And really we were raising questions then. I think now, a year later, we're going to continue this discussion, and maybe we'll try and provide some more answers. Was that the idea that we can have a one-size-fits-all approach for global health was never fit for purpose, but certainly is not now, because countries have changed so much. That's one of the partial successes of global health, right? And I think we've known that for a long time. So basically we said, well, there's the key function is convening and stewardship. And that's never going to stop being important. Let's look what's happening now with the Ebola outbreak in DRC in Uganda, the hantavirus outbreak on a ship coming out of the Patagonia. You still need that convening function, that collaboration function, that stewardship function, that sharing function. That's never going to go away, however advanced all countries become. That underpins everything. But then we thought specifically, we talked about substitution. Substitution is where external actors do things which are the responsibility of national actors. And we basically said we should stop doing that. Right? And we've seen that in the recent crisis. We saw that in some countries, overnight, people were locked out of their own country's data systems because people from other countries of goodwill no longer had access to their computer systems and no longer had the passwords. How is that possible? Right? We saw that clinics stopped providing services overnight because of decisions made on the other side of the world. How is that possible in 2026? So we need to stop doing that, except in a very limited set of circumstances, because unfortunately we live in a world of growing war and conflict. We have more wars now than we have had since World War II. That there are places where it's so challenging, the state doesn't have jurisdiction, where perhaps some substitution will still be needed by external actors, or for marginalized populations, which for whatever reason undergo structural discrimination in their countries, and the state is not providing for them, and there may still be a role for substitution, but that should be the exception and not the norm. Then we said there is traditional financing support and technical support. And we made the argument that probably we're doing that in places where we shouldn't be doing it. But really countries should be able to now do it. But that will still be needed for a set of countries, for a set of low-income countries that are stable, and probably for some of the humanitarian settings, and maybe some of the low-income countries. But then for most countries, it really is about the global public goods. It's about the data. It's about the norms and standards. It's about shared experience, cross-country learning. It's about research. It's about innovation. Those things all countries still need. They need to come together and share. But we had a nuance on that. We said there are global public goods which are created for sharing that then countries apply within their countries. And there are global public goods to address transnational threats. Those threats that no one country can address by themselves. Emerging infectious disease outbreaks are certainly one of those cases. But also in terms of innovation. Not every country can have necessarily the biotech industry that to develop from de novo a vaccine for themselves, right? But obviously we need to do better than we did in COVID in terms of the equity of access to those innovations. So that's sort of this taxonomy that we had. And I think now with all these further discussions, we're thinking around more definitively, what does that mean for the reorganization of the world of architecture? Just to finish this initial intervention, I'd say, just to reflect, given we're here with this CISDI. In 2013, when we were developing the Sustainable Development Goals Health Agenda, the UN system had something called the World We Want dialogue to engage civil society and all partners. And WHO and UNICEF were invited by the governments of Sweden and Botswana to coordinate that discussion together. And I was the focal point for UNICEF. And we were gathered in Botswana, invited by the government of Botswana for the high-level meeting that essentially, if you look at what came out of that, set the SDG 3 agenda, whether you like it or not. If you like it, go down. If you don't like it, that's something else. And I was seated at the dinner next to Excellency Minister Ibu Nafsia Mboe, your former Minister of Health, this very impressive woman in Indonesia. And after 1 hour of pleasantries, I sort of said, Minister, do you think in 10 years, Indonesia, at that time I think had about 200 billion people, 17,000 islands, will you still need WHO and UNICEF in the global system? And she said, come on, of course we will need WHO and UNICEF. And then after another half an hour of the dinner, I said, but really, Minister, will you really? Why will you need us in 10 years? You're such a big country, you have so many smart people. And she said, I'll need you still, honestly, coming for 3 things. I'll need you because I'll always be interested in innovations, right, and sharing experiences. I'll still need you because I'll always be interested in my staff and my people working with international partners, sharing, learning, strengthening capacity. And then she said, if I can say it, she said, I'll also be interested in you because sometimes foreigners tell me things that my own people won't tell me. There's sometimes an accountability function, right? Okay. But then she said 3 things I don't want to see. I said, I don't want to see pilots with 17,000 islands, hundreds of millions of people. Why are you coming to me with pilots? I don't want to see things where people fly in, and it's not my own people doing it, but if people fly in and fly out, it's not useful to me. And I don't want you to come up with these ideas and assume that we have a vacuum of a system. Anything that you come up with, we have a system with decades of experience. It needs to work on our existing system. I have told that story so many times. If you see Ibu Nafsia, please thank her for that. I don't think this crisis shows that we have adhered to that very wise guidance. And I think in this moment, it's past time that we make sure that we just live up to the promises we made in the past about country leadership, about community leadership, about the way that is the right way for us to work together as the world for global health.
Fantastic. Thank you so much, Kumanan, and what a full circle moment in some good ways, and as you said, really showing how the ideas have been there, the seeds have been sown, both for the challenges but also the opportunities we have today, and a really helpful taxonomy, I think, for thinking about where, substitution of financial assistance is still relevant, but also liberating us to focus collectively on the global public goods, the transnational threats, the innovation and research that really needs to push forth to the next step. Mikkel, to point to one of the those functions that Kumanan has just discussed, you are with the Pandemic Fund, which was also created in response to a crisis with calls for greater solidarity and equity and country leadership. Looking back on that from today, are there lessons from that experience that you think are important for the audience to hear? What did we get right and what can we still learn from?
Oh.
No pressure.
No pressure, but speaking after the two first ones, it's quite something. I want to start by adding a line to Dia's CV, because she was one of the early board members of the Pandemic Fund, representing Global South civil society, and she has been a tremendous ally at this time. So thank you. And I like the reference of the global as architecture industry. And honestly, it would be sometime good to ask ourselves who benefits from this conversation. I have the feeling that the last year has been a tremendous journey based on trucks and cows, but they are also part of this conversation that is an industry, and people are spending hours to do that when, honestly, our people are asking us to deliver. So we need also this trade-off. Spending hours to negotiate agreements, architecture, and things like that is costly in terms of time, energy, travel, hostel, Jenewa hospitality industry benefit from this, I think. But just back to the Pandemic Fund, just to remember that it has been created to fill a gap in the global health architecture based on the lesson learned from COVID-19, but also previous pandemics, especially to provide MICs with funding for investment in pandemic PPR, because previously the level of investment were really low, existing mechanisms were not able to mobilize. So the understanding from the global community, not only based on the COVID, and to be honest with what mentioned before, deciding that we need to do more, and so try to find a way around the G20 presidency, first Italian one, then Indonesian one, see what can facilitate. And they decided to create the Pandemic Fund, hosted at the World Bank, with the idea to catalyze money to fund the PPR capacities through co-financing, but also through co-investment from the country. And I have to say that 3 years and a half after, 3 calls for proposal, 1.4 billion approval, leading to a 11.5 portfolio. We have currently 67 projects covering 128 countries. Those are just numbers, but those are critical projects that bring additional capacities in laboratory, surveillance, and workforce. Our 3 priorities for the moment. I was in Philippines and Cambodia last week. You can see what is going on there, not only on the human health side, but also in the animal health side, through the One Health approach. Is it fully right everywhere? No. It's a new institution. We are not doing things really at once and by ourselves. We're based on a cooperative and coordination model, so through implementing entities, UN agencies, but also multilateral banks and global health initiative. Coordination is an easy word. You can mention it, but on the ground it's not easy. Country-led is something that is key for the pandemic fund, because the idea is really to answer the question raised during those periods and to avoid that the stream of money goes to parallel system. So the idea is really to catalyze, being centric, and have the country leadership at the. I have to say that what I saw on the ground is not always perfect, and there are always tension between actors that they know how to implement capacity, they have the experience from many countries, and countries that want to lead and to know also how to operate. So the tension between OIs and the countries somehow sometimes not so easy. So I would say that we have a proof of concept, and the conversation, for example, on PPR is different in the global south and in the global north. My feeling is that the conversation we have in Addis Ababa, the conversation I had in Manila and Phnom Penh recently, put PPR still at the top of the agenda. Before antivirus, before Ebola outbreak again, where this is not the conversation we have in New York, in Geneva, sometimes in Brussels or somewhere else. There are many crises. There are many competitive priorities, lack of funding, and it seems that, well, the best way to enter in this conversation is back to what we know and what we did in the past. So being conservative in a way. Many words are on reforms, but at the end, what will be the reform, is it worth it, and so on. I don't know. I have the feeling that what our funders try to achieve with the pandemic fund through inclusive board, bringing ownership, shared ownership amongst contributors, co-investors, civil society, and philanthropy, a country center financing platform providing blended funding that catalyze external financing flow and bring those finances into a coherent country-centered design vision and efficient, because we operate with a really smallest administrative cost, was in advance of this conversation. And now we are under pressure to reform ourselves, which is crazy, because our model was different. And regarding the lesson learned, this is only the beginning. There are tension, country-led, I will come back to that later, is a nice word. In true reality, that's not always easy, clearly.
Thank you so much. And yes, look forward to coming back to hearing some more insights on the ground. Yes, we're going over that way, but there's actually a second.
Sorry.
No,
Oh, great.
I think we've talked, and thank you for reminding us that it's easy to get caught on process and to feed an industry rather than to take concrete actions towards a new way of working. I want to come to Lutz next, because I think you've really pushed for a different way of working as industry, as a pharmaceutical, in the pharmaceutical industry, really leading the shift from charity or CSR, as Dia pointed out, to thinking about access programs. Can you take us through what that has involved, what that's meant for how you rethink the business imperatives, and if I may ask, what there is still yet to do, where we can still do better?
No, absolutely.
It's, yeah.
Is it on? Yeah, okay. So first of all, thank you very much for having me and giving me the opportunity to contribute to this very timely and very relevant discussion. I mean, first of all, I'm really excited and encouraged to see how far we have come in just 1 year from the last time that we met here in May to this year, where last year I think people were still largely in shock to what had happened to global health and trying to hold on to the old system. And I remember discussion about who is replacing the funding of the US government. And I'm glad that we've realized that no one is going to do that, and that we need to lean into that change and to embrace the opportunity. And I would just hope that we are all sort of mature enough to really see that we need to fundamentally rethink the way how we build this new architecture. And I'm not sure that anyone really knows exactly what that new architecture is going to look like, but I see some emerging themes, some trends, and some characteristics which equally are very encouraging. So I do hope that by the end of the day, we don't just build more organizations and more offices in Geneva and New York that coordinate a chaos, but that we make fundamental shifts. And the way that I would look at it is that we need each and every organization, each and every sector needs to focus on what are the core competencies that we bring to global health. Because to your point of substitution, we also saw not just between countries and supranational organizations, even between supranational organizations, we saw substitutions. We saw mandates mushrooming because we had the luxury of moving beyond our core competency. Now, for the pharmaceutical sector, what does that mean? I think pharmaceutical companies are excellent in discovering, developing, and delivering new medicines. And I think that's what we need to maximize and what we need to leave to the pharmaceutical companies, but at the same time, create a framework that holds those companies to account to doing this ethically and equitably. And that's sort of the shift that we've done in Novartis, but also other companies, of course, have done this over the years, that previously we were looking at business as profit maximization and then complementing that with corporate philanthropy or with CSR. And the path that we've been on is to integrate that, to say how can we deliver a shared value proposition through our core business and run our core operations in a way that it's not either or, it's not either philanthropy and humanitarian, but to make the business a force for good. And that requires the mindset shift that we embed access particularly and equity into our core business. And one example that we've done at Novartis is that we set up a dedicated unit for sub-Saharan Africa, which is not being there to deliver profit. It's actually almost run like a non-profit in a large for-profit organization, but we invest whatever money we make in the continent, and we do this sustainably. So we are not subsidizing it, but we also not extracting value. And I think that's a model that I would like to see more broadly adopted, and making sure that we reframe the way how we do business from profit maximization or philanthropy into maximizing the societal impact that we are generating. And I mean, it takes time, it takes commitment, but we've demonstrated that it can be done. And I'm glad to see similar approaches now also being taken elsewhere. But let me come back once more to the core competencies, and here another, I would say, call out to the private sector, which again, we fall a little bit into this old trap, and that's on some of those neglected tropical diseases, where it's great to donate medicines that were developed 50 or 70 years ago, but we shouldn't stop there. We should remind ourselves about the core competency lying in discovery, development, and delivery of medicine, and use those very competencies also towards diseases that are market failures, where there is essentially no commercial model to be made, and ensure that we use the same level of expertise to also not leave those diseases behind. And I must say, I'm disappointed to see that some private sector players actually drop out of that space and withdraw from global health. And I would hope that we can find beyond the private sector mechanisms and maintain those mechanisms. The Global Fund for Malaria, AIDS, TB is one of those examples where you at least have a certainty that your medicine is being procured at cost of goods, and that there is a path towards bringing it to patients sustainably. We cannot jeopardize those mechanisms because they are vital in order to create a framework that allows dedicated pharmaceutical companies to continue investing in that space. I'll stop here and
we'll come back a little bit more to think about where else and where we go from there. But I think the point around core competencies and what is the real unique value add that we can bring is a question we all need to be thinking about. And I'm going to bring that question to my colleague David. As the program, we sit across many competencies, but really a core one being around evidence generation, knowledge production. Where do you see academia and Harvard particularly, and as an institution in the global north with a lot of privilege and a lot of power and authority, how do we need to change in the way that we operate in global health?
Great, thank you, and nice to see so many familiar faces and friends in the room, so thanks for coming out this morning. So let me answer that question by taking us back to 1640. When Harvard formally adopted its model now, which is truth, veritas. And that model, that motto, has been subsequently adopted by many other universities in the United States and then exported elsewhere to universities in the global south, as well as exported back to Europe as well. And the core competency of the university and the university ecosystem has been truth and truth seeking. So what does that have to do with today and in this chaos? And I think that we have to acknowledge that the university system across the world has been, on one hand, seen as the protector of that truth and the creator of the new knowledge, but on the other hand has become a bit too insular in who gets to define truth and who gets to define knowledge and who gets to define evidence. And speaking from the academic medicine, from the academy that is focused on the health sector, is that we've also then veered more towards the biomedical model of healthcare delivery, and in discovery as well, and really placed mostly all of our eggs in that basket and pushed away other systems of knowing and of understanding. And that's led to, I think, or has contributed to the state of our world today, where we have seen so many reports, even before COVID, but definitely after COVID, of trust in healthcare and trust in healthcare systems declining at a significant rate in both high-income and low-income countries, because we have failed to acknowledge other potential truths that exist, especially from the social models, especially from the lived experience. Over the course of the last 3 years, on the Lancet Commission for People-Centered Care for Universal Health Coverage, it's been a learning journey for me, pushed by a lot of our commissioners who are commissioners with lived experience, to understand and explore other models of understanding of truth and how that informs our understanding of the socio-economic, medical models that we have. So, Bethany, to go back to your question about what is the role of the academy in all of this, I think that we need to have a serious look at ourselves about being the protectors of truth and the creators of knowledge, to see how do we build a more inclusive community and engage people who traditionally are not the full professors, who don't have all the academic credentials and degrees that we typically associate with knowledge and truth, and then maybe power even, to bring other folks into the fold and recognize that their lived experience or their experience and their understanding and their explanatory models of why certain things are the way they are can also contribute to our broader understanding of knowledge, of evidence, and then through that allow us to develop solutions so that we can then build a better world, a better system for healthcare and healthcare delivery to protect health and also to eliminate illness and disease.
Amazing. Thank you, David. And I think feel the excitement beside me for Anita to respond next when it comes to the truth of how systems really impact real lives and the knowledge that patient advocates like yourself can bring. Could you share, maybe introduce yourself, your work, your experience, and what is the value, what is the knowledge and expertise that groups like International Diabetes Federation can bring to this conversation and this new architecture? Thank you, Anita.
Thank you. Hi everyone, I'm Anita Sarvidi from Indonesia. As earlier introduction, I lived with type 1 diabetes 28 years ago. Later I was diagnosed with cardiomyopathy and chronic kidney disease. I work closely with IDM, Gender Transportation. Also, I'm also a patient advocate for global Harkat. So in terms of global health architecture, I completely agree with David and also earlier about no one size fits all. Why? Because when you have this guidelines, but you will miss the socioeconomic and political and cultural part. As an example, I'm using Indonesia as an example. So we have an estimated 3.6 million women with cardio conditions, but we only have 560 female cardiologists. Well, we are culturally and religiously dependent on female-to-female approach. So that's why I think a few days ago we had the discussion why in Indonesia we are one of the lowest female patient engagement in healthcare system. So that's why we need a more better approach in terms of implementing the global health architecture based on their certain countries and also based on their certain regions, because we have all different approaches as well.
Wonderful. And maybe you could share a little bit more about the way in which your organization has been invited to be part of this conversation about how communities can have a voice in reshaping global health architecture.
So back in Indonesia, we conducted a project named Women in Diabetes. So we try to empower the patients, especially women, in terms of prevention and also empowering them on treating their chronic condition. Why? Because we know the hurdle it takes to fight the culture in our country. So instead of battling the culture, so we empower the patients. And that message is carried well globally as well. Why? Because it takes a lot of voice to have our self being supported, because it is really not difficult as a woman. So that's why I'm also carrying this project also along in IDM, also in WHO. We talk about women a lot in terms of gender perspective as well.
Wonderful, thank you. I'm going to come to circle back, and at this time, any panelists who want to build on the comments that have been shared, please do so. And then we'll be shortly coming to the audience for some questions, so have those ready. But just building, Anita, on what you said about how much strength it takes to really have your voice heard in these elite spaces, like the WHO. Kumina, maybe I can come back to you to say, what do we need to do? Who needs to create that space for civil society, not just country ownership, but that the civil society and marginalised populations to also have a voice?
So I first came to the World Health Assembly as an activist, actually, as part of the People's Health Movement 20 odd years ago. And I think in many ways, maybe I'm biased, but one of the things at the end is that the World Health Organization, if you go to its constitution, written almost 80 years ago, it's one of the most idealistic pieces of text you can see. It's still very relevant. At the Alliance Health Policy Research where I work, I always, any new staff member, I say, please go and read the Constitution, and then go and read our bylaws and our mission statement from 30 years ago. These are idealistic statements around human dignity, around the right to health. The premise of the World Health Organization is that it's as an organization of the people, where every country, whether you are Tonga or whether you are China, you have an equal voice. Right? But it's not just about member states. We talk about member states. What are member states? Governments are here to represent their people. So I came as part of the People's Health Movement, but the World Health Organization is a people's organization. I had the privilege of getting to know Dr. Halfdan Mahler towards the end of his life, who is the father of primary health care. And I used to take him to Cordovan and wait for his train to go home to Kobe. And when you talk to him about what inspired his passion for primary health care, his experiences as a TB doctor in the 1950s in India, the passion around primary health care, it is around the right to health and about people's participation. Primary health care is about participation. That's one of its key principles. Right? We have struggled to realize that. So in many ways, global health, for all its flaws, has as one of its founding principles the human rights-based approach and the principle of participation. Now, have we lived up to those aspirations? Not always. But I think one of the things that people should acknowledge is that in the last 25 years, the global space in global health, the World Health Organization, when you're in a meeting, you can walk up to anyone and talk to them. Right? There is a culture of openness that I think we really should treasure and celebrate and preserve. Now, one, I think, problems, so at the moment, we are talking about a lot around health sovereignty and national sovereignty. But we shouldn't forget that part of the success of global health was sometimes the substitute for spaces where country governments were not delivering for all of their citizens or for specific communities. And of course, the seminal experience of this current model of global health is the global HIV movement, HIV/AIDS movement, where people came together and said, no, this idea that we can't tell time, that we can't take pills, that we can't have access to these expensive medicines, no, that is not acceptable. People have a right to health. And therefore, that model, it wasn't about countries' governments. Sometimes countries' governments were saying that's not possible. And then that was taken up by organizations like the World Health Organization, Jim Kim, the 3x5 movement. That's been very powerful and has delivered great progress. That led to the formation of the Global Fund. Civil society was instrumental in doing that. So we have to be careful that we don't throw the baby out with the bathwater, that we don't lose what some of that global space has achieved. However, as Anita said, sometimes Richard Borton wrote in the last, I think a year or two ago, about the pretensions of global health elites. That was actually based on a meeting that I was also at Wilton Park, which, if you've been in the south of England, is an elite space. We cannot deny that, right? And sometimes even in civil society, we've created global elites in civil society, right? In that our civil society counterparts, some of my friends stopped talking to me when I joined the World Health Organization. They said I sold out and become a bureaucrat. I think they were sort of joking, but not really. That really, whether you come from civil society or private sector or government or academia, if you're sitting in a room in Geneva during the World Health Assembly, are you really so different in terms of your class status? These are elite spaces. We have to acknowledge that. And so the question then becomes, do we solve this issue of participation by opening up these elite spaces more? Because at the end of the day, the number of people who can fly to Geneva for the World Health Assembly is a very small minority of the planet, right? Or do we say, going back to the constitution of WHA, that countries need to represent their people? Right? Can you substitute for democratic deficits within countries through global mechanisms? And I think we've tried with some success over the last 30 years, but I think we're moving to a moment where that is going to be increasingly difficult. So yes, absolutely, and I think we take it seriously here. We do try to improve the access and the diversity of who can access these spaces and these two mechanisms, but that is always going to be a partial solution to the greater challenge of democratic deficit and what we're seeing in the trends in our world. And that
as I often say to my civil society friends, is a national struggle or a subnational struggle, and not something that you can only solve by coming to global events, right? But that, as we know, it's a challenging time for civil society space in a lot of our countries these days. And the world, in many ways, that is becoming more and more difficult. So I don't think we can completely solve that at the global level.
No, absolutely. It's really requires that kind of institute, that shift, that space to be created, on the ground in community. And I'll come back to Dia, I think, on this point to ask back when we're talking about the Primary Healthcare Impact Lab, as we started this conversation, what is it and how are we putting people and communities at the center in a really concrete way in terms of governance?
Yes, I think from Kumanan's explanation just now, we see how big the space is and how complex and how layered problems are, how different one community is to another. When we planned for this Primary Healthcare Impact Lab, it was by design that it should solve the problems in that community. So it was by design that we chose to start with the two communities and then make it as an example of, okay, what is the similarity that can be drawn to other communities? And then we start from there. Without having illusions that we can solve the problems in those two communities at all. Because I think primary healthcare would not be primary healthcare and should not be primary healthcare if it does not serve communities. So it has to be able to answer to a particular context that communities face. And with the diversity of Indonesia, we can spend another 10 years and I can happily report to Ibu Nafsian that we still cannot solve it. I think it is an ongoing effort, it's an ongoing battle, it's a long game. And that's why it cannot be solved just by us who work in the health field alone. So I think another shape of what success might look like is inviting those unusual suspects and with the similarity and alignment in values that they too want to serve communities and they too do not want to extract value, they want to add values to communities. And I believe that is exactly what my partner, Pak Syahrial, said in one of our early meetings, that they want to add value instead of extracting values. And I think alignment in values are the most important to go back to communities with that. But also, I think in this space of global health, we tend to have the illusion that we are given space. But I have to go back to what Anita just said, that they are demanding voice, that people with lived experience do have the same, the right to health, and perhaps the most right if we talk about that from an equity lens. So I think for me it is working in primary healthcare for now 14 years. I think it's a humbling experience that I do not have the right to give anything to anyone. We share the same space. And I think that should be and we serve communities. We do not serve authorities or power or whatever. We work within the system, but we serve the people. And in order to do that, we have to hear what they want. We have to think from their perspective. And so many now people with lived experience are having different demands having different voice, and I think each and every one of those groups deserve to be heard. And I think it is us. In this endeavor, in this beginning of the journey called Phil, I think we have a good start because all four of us, the three co-founders and the one knowledge partner, we all share the same value of wanting to listen to what the people demand, and then and they know and we know that we serve the people. I think that's the essence of primary healthcare.
And yeah, building on that, there is a commitment there to listening. How do we make sure that that is not lost, especially when potentially academic incentives are not completely aligned, perhaps other interests?
CISDI has 12 years of experience working in primary healthcare in Indonesia directly with communities. We have a repository, if you want to say it that way, of best practices, what work, what do not work. But that is, of course, where you come in. Your team comes in with experience from other countries, with specific tools and knowledge and scientific rigor that can challenge what we know from Indonesia, and then we can find a common solution together with communities. And we are expecting different models of care to come out from primary healthcare impact lab. The first two perhaps will serve the specific city of Tegal and Brebes, but then we will try to expand and give more models of care through community advisory boards, through engagement and co-creation with communities, and also with knowledge that the Indonesian government is already setting up an integrated primary care model where we work within that system. And CISDI is now working with 4 of the primary healthcare consortium on research. And then we are also advocating as members in the human resource and in the service delivery working group. So we work within the government system, but we challenge with Phil, it challenges what can we do more, what can we produce better for the people we serve.
Thank you. Lutz and David, I'd love to hear from you on that same point. What do we do, and how do organizations honestly respond when there isn't a perfect alignment of priorities with community and what they require and demand for health?
Thanks. To answer that question, let me pick up something that Dia just said about being in spaces, and I think other panelists have talked about being in spaces, and I think that's really important because the space that you're in, and a lot of these spaces are in the global north, in Geneva, in New York, Boston, that kind of creates this like echo chamber and bubble about priorities, right? And I think one of the roles that universities, including my own, are grappling with is what are the spaces that we occupy? And especially in the current political environment in the US right now, we've had to face this very uncomfortable question about, how we occupied this particular space and how we've kept it so exclusive, unfortunately, for many, and fortunately for some, that has had this backlash against us. And then when the opportunity for Phil and the engagement with Indonesia came up, the space of Central Java in a very rural place that's not, as Pat Serdeman said, it's not a showcase city and it's not a capital city. So why would a university like Harvard go there when we could have gone to Jakarta, and we've had invitations to the premier elite university, the University of Indonesia? Why not there versus this very rural location in Indonesia? And that goes to this issue of spaces. And at this moment in time, what is the space that we also want to be a part of, and that's close to the communities and it's close to people, so that we can learn, listen to, and co-create new knowledge with. And I think that's really important, because that's a kind of a power dynamic, power differential that we're struggling with right now, because in this period of scarcity, in this period of just wanting to pull up the drawbridges and just like kind of focus in on ourselves and be very protective, I think that's what got us into this position in the first place. And now we need to utilize the limited resources that we do have and actually engage with communities. And it doesn't take us across the world to do this. During the pandemic, and because of the pandemic and what was going on at that time in the US with the Black Lives Matter movement, Harvard also had a moment of reckoning, of thinking we're so engaged in the medical miracle mile that is the Longwood Medical Center, and we weren't engaged in our communities, the next kilometer, which was in Roxbury and Mission Hill, which had a maternal mortality rate the equivalent to Bangladesh in some parts of sub-Saharan Africa, and yet our maternal mortality rate, less than a kilometer away, was much higher. And we really had to grapple with that, and I think that we're kind of in this moment again of spaces and where we intentionally choose to be in and to be a part of. And when the opportunity came up with Phil, I think that we wanted to kind of make this leap to be in a space that we would also be quite uncomfortable in.
Yeah, I think building up, David, on what you just said, I think it's two elements in my mind. One is that we need to be willing to step out of our comfort zone, and sometimes that is discomforting to be confronted with observations, with notions that do not fit into your value set or that cannot be easily put into a drawer. But I think that's where, in my experience, the magic really happens, where all of a sudden you are able to connect dots that you previously couldn't connect, or where you open up your horizon, and that requires not sitting in an air-conditioned office somewhere in Switzerland, but really sort of going into the communities, understanding, listening, doing a lot more listening than speaking, and really trying to understand what is the ecosystem that ultimately we want to serve, and then how can we best servants to that ecosystem, rather than bringing in a preconceived notion of what the solution should look like. And then the other question to me also is a bit like reframing. And I think here, also in the global health space, between the different global health actors, we can do a lot of that reframing. And I'm asking myself sometimes, am I a pharmaceutical executive looking after global health? Or am I a global health physician whose career path now is in the pharmaceutical industry? And that's a very, very different mindset. It's still the same person, but I could approach a question through one lens or the other lens. And I think it's obvious that it's the latter that matters to me more than the former. But I think we all have different perspectives that we can apply to a certain situation and to an issue. Let's make sure that we sort of leave the beaten path and that we look for opportunities that match with our competencies, with our experience that we bring, but be willing to reframe those.
That's wonderful comment to finish this round on, unless anyone else has to, yes.
I think just very briefly though, when we worry about participation, as I said from my previous days, people used to make the point that I think others have alluded to, is that empowerment is not about being given power. Empowerment is about people seizing power. And in a sense that if we are in a moment where perhaps the global will be less dominant for a number of reasons, and I think that's true, that the nation state has become again more and more important, then those debates within countries are going to be more and more important. So again, national sovereignty is not just about the government, it's about the whole of that society. And so people then have to express and seize power for what they want. I think the other factor, and so again, the conversations perhaps for global health in Geneva will become less important, but there will still be a very important role to come together in a global coordinating authority, and dare I say that's the role of the World Health Organization. But the other factor is that how rapidly our world is changing. We have a session on Friday night on the future of health systems, which you're all very welcome to, where we're going to consider these issues. I mean, AI has many concerns, but it can really be a democratizing influence, right? I mean, people are not going to have to wait for universities to open up. People will be able to do research, can already do research. You can do a systematic review yourself now with AI, right? Many of these methods that have been mystified and codified in abstract legal spaces are going to be much more accessible to people. You can make a 1-minute YouTube video to communicate your cause easily now, right? I'm not romanticizing or ignoring the digital divide. That is going to rapidly change and disrupt the academy. It's rapidly disrupting health systems. We as gatekeepers will not be able to keep the gate, right? And so this is going to change in the way that people's relations to the media industry change. 20 years ago, people said in Kenya, how will people in Kenya ever have banking accounts? And people find a solution, and technology enabled those ideas. And so I think for us to say, well, how do we open space is the wrong question, because that space will be opened in this time of rupture. The question then is, are we supporting and steering those forces towards equity and greater access and greater effectiveness? Or the risk, there's many risks. There's a roundtable on misinformation and disinformation tomorrow at WHA, which I'd recommend to you. There are real risks around safety and governance and equity and privacy and security and dystopias where we could go. But we should not ignore that there's huge potential and that we cannot, again, just as always in the health sector or in the academy, be reactive. We should be thinking, what is our role in steering this to something that could really facilitate much greater participation?
Thank you. I think that's a wonderful time to turn to our audience and allow you to make us a little bit uncomfortable, I hope, and ask your questions. So there's Anuga, I think we'll bring the lady at the back has a question. If you wouldn't mind introducing yourself and then jumping into the question. Or just feel free to come up in front.
So my name's Alev Mine, I run the One Goal Initiative for Governance. So I have various questions for the Global Fund. There are some
And to Mikhail from the Pandemic Fund.
sorry, Pandemic Fund, yes, long week. There are some people who want blended finance, and there are some people who don't want, expressly don't want blended finance. So what could motivate people not to want? This is a genuine mystery, I don't know, so maybe you can give me a hint. For academia, the knowledge that is created, first, what is possible to create depends on the basis of knowledge upon which informs, I guess, exploration. It also changes the marginal value of the added knowledge, because a new piece of knowledge attaches to existing pieces. So therefore, the knowledge that is locally produced and comes to, I guess, global academia is one way. And then what about the other way? Like the knowledge that is available at a global level to academia, how is this transmitted to the local populations such that there is actual maximization. And then for you, the shareholders, I understand, can under certain circumstances change the purpose of the organization. And if we take this possibility and the fact that you said some companies move into or out of this kind of or this kind of area like TB or malaria, etc., that would be able to, that is important for everybody, but that would not bring particular profit back. So if there are like two populations of companies that arise, how are we going to govern this? Should they start having different statuses? And so these are the questions. Thank you.
Thank you. So I think the first question around the structure of financing and who chooses those to become, and come to David and Lutz.
Yeah, it's only Wednesday, so just to mention that we have a following week.
Yes.
And Pandemic Fund is our mandate is disease agnostic, so we cover whatever the pathogen will happen. The question regarding blended finance is regarding debt distress and things like that. So we won't have the ideological debate today, but the role of NDBs, and especially the World Bank, is to provide financing for countries to build their own action, to bring infrastructures and policies that can make the planet better and try to end poverty in a way. And you have great success in a lot of countries. Of course, you have countries with debt distress, and there are mechanisms that address this, but the overall system of public financing from NDBs is a way for countries to access a large amount of funding to bring new policies and infrastructure. We are not always acting with blended finance, but the idea in our grant is that it's not free money. If you want sustainability with the capacity you provide, you need the country to invest. And not all countries are in debt distress, make it clear. So, for example, when we launch a call and we have a project at Summit, it needs to have a large portion of country money and with a larger portion of co-investment, co-financing from international sources. So one of the interests of our grant is that it can make IDA grants and IBRD loans, for example, for the World Bank more appealing for a country, and they can invest more. That's the case, for example, for Indonesia, but from other countries, also to bring more capacity in a short period of time. And the cost of those loans are lower with our grants. And the message behind that, and also to be clear regarding what happened in the last year, is that when you incentivize countries on PPR to invest, they are doing it. So it's not like they are waiting for us to achieve, but they didn't do it in the past. So the mechanism that incentivize can work. The question mark is, do we have enough money to meet the demand? And that's another question. I will be clear. Each time we launch a call, we have between 6 and 6 times the amount requested. So there is a large demand to invest. We need donors from different sources to come and to meet the demand. We have a proof of concept, and if we don't want more outbreaks becoming a new pandemic, we need to do it. We need also to ensure that countries decide by themselves and that other actors are not pushing them to do things that they don't want.
you. Just a brief, we've got about 5 minutes left, so a brief word from David and from Lutz.
So the your two-part question on knowledge generation and then transmission of knowledge. So the first is that I think that, and we've been grappling with this as well, is that our knowledge base in generating new knowledge based on existing knowledge, there's an inherent bias to that, especially in the biomedical space, because we're leaning on the biomedical model, right? So we are looking at how do we come up with new ways of generating knowledge and new approaches, and that's also uncomfortable. Is it always like randomized control trials and systematic reviews and analyses as the gold standard, or are there different ways? So that's a conversation that's ongoing. And then the transmission of knowledge, I think another panelist alluded to, with AI and technology, that the barriers come down. But there's also continuing to be significant barriers with access to journals and access to knowledge from that perspective. So how do we reduce those barriers? And I was having a conversation with one of the editors of the New England Journal of Medicine a week ago, talking about this very issue and what their role is as a gatekeeper of knowledge with the advent of AI. And how to work with AI and technologies to actually decrease that barrier of entry, and not just through open access, but through the accessibility of both the language used and the methods used.
On the question around the private sector, I would first of all argue that every pharmaceutical company or company that is active in the health system has a social mandate, whether they like it or not, because ultimately the goal is that through those products that come out of those companies, you improve health, which is not the case for many other industries, but I think that distinguishes the pharmaceutical sector. So the question then is, how important is that purpose relative to some other inherent purposes that you have as a private sector player? And here we do see a gradient between different companies. We see different companies taking a different approach at different times, which often depends on the leadership at the very top of the company, and that's my experience more the probably CEO and executive team and their commitment than it is necessarily the board of directors, even though they do play a role. So I didn't mean to criticize those companies who are taking a step back at global health, but I see it as a missed opportunity. And what I'm trying to do is to convince other private sector players that even within the framework of a for-profit organization, there is a lot of positive societal value that you can generate, and that you shouldn't shy away from maximizing that part, because it is not a trade-off to your profitability. It can actually be accretive if you do it wisely, but it creates so many additional value proposition, whether that is employee engagement, whether that is your credibility, your reputational value. There's a lot of positive byproducts that in themselves should also stimulate companies to take a bigger step into that area, rather than to retracting again into a frame in which they are very comfortable and which is very predictable.
Thank you. We are coming to the end of the panel and the discussion, so I want to be respectful of everyone's time and take a moment to wrap up and say there's been a lot of great points raised, a lot of really key insights. Some of the things that I'm going to take away are the importance of stepping into uncomfortable spaces, of recognizing that we don't need to throw the baby out with the bathwater, that there is really strong roots in our global health architecture that we can build on and learn from, of seizing power and recognizing people's voices in all spaces, not just the elite ones, of connecting with unusual suspects and transcending the labels and boundaries that we put on each other and on ourselves when it comes to what we can contribute, and ultimately sharing power and finding those spaces for shared value. So I want to ask you to join me in thanking all of our panelists for a wonderful discussion. Hope you have a wonderful rest of the week.